Hi everybody, it's Erica. While I'm not necessarily a board-certified neurologist, I'm an amazing neurology podcast co-host. And I'm here to tell you something today. I've heard the neuro boards are tough, but they don't have to be. The University of Pennsylvania offers a stellar board review course for first-time test takers and recertifiers that you can access online or in person in Philadelphia. Go to penneuroboard2018.com and use promo code WAVES2018 for $150 off your course fees. That's WAVES, in all caps, 2018. Oh, and good luck.
Hey podcast listeners, Jim Siegler here for Brainwaves. The other day at work, I was in the middle of a conversation with these three guys, three sons of a patient of mine, talking about their mom, who was in the hospital with a stroke. It was a serious conversation about how badly she was doing, and I don't like having these conversations. One of the guys interrupted the other and asked me point blank, "How do you want to die?" Now I didn't really know what to say to that. In the context of that conversation, my answer would be incredibly different than if I were having a conversation with a friend, or a family member, or somebody that I work with at the hospital. Which I think is an important distinction to make, because as physicians, I believe we think about ourselves differently than the way that our patients think about themselves. As healthcare providers, some of us believe that this difference is because of how much illness and death we surround ourselves in, how we know the limitations of modern medicine, and what experiences we've had that have built up some sort of wisdom when it comes to prognostication. This mental difference between patients and providers has been written about countless times, and you can find links to this on our blog. At the time, during the conversation I was having with that family, all I could think about was their mother, a 97-year-old woman with dementia and a failing heart and kidney disease who lived in a nursing home, whose sons visited her maybe once a week for the last 2 years. And she was admitted with a new heart attack and a simultaneous new stroke, one that had left her with the inability to communicate or to move the right side of her body. The stroke left her sleepier than usual, unable to swallow on her own, and not even alert enough to know that she was surrounded by her family. "But we want to give her the best chance," they said. The best chance. The best chance for what? I thought to myself. The best chance for her to eventually say a word or two? The best chance to be able to tolerate an ice cube in her mouth without choking on it? The best chance for her right thumb to wiggle? That kind of best chance? Now I knew that these were the only realistic outcomes in this particular scenario. And that's kind of what I told this woman's children, that it would be unlikely for her to accomplish any more than this, even with an optimistic recovery. That's my interpretation of the best chance. It's what they wanted. And to give them credit, they loved their mother. They'd obviously do anything for her, to spend just another moment with her. I would see one of the brothers in the room, gently holding her hand while she slept, cleaning her mouth out with the suction tube, wiping the crust from her eyelids. They wanted what was best for her, and to them, it meant giving her the best chance at survival. "How do I want to die?" they asked. Not that you all probably care about how I want to die, but, God, I really hope I don't live to be 97. To spend the last few years of consciousness in a nursing home, to spend my last few days or weeks or months struggling to breathe from heart failure, weighed down by edema, bound to a wheelchair, or to be trapped inside a body where I can't even communicate my wishes or understand what's going on around me. That must be terrifying. I can't even begin to imagine the humiliation of having my excrement cleaned off my backside by a nursing assistant several times a day because I'm not even strong enough to get out of bed, or cognizant enough to ask for a bedpan. I don't want to think about having to be repositioned in a recliner every 2 hours just to prevent skin breakdown. I don't want to be shuttled back and forth from the nursing home to the hospital for pneumonias and fevers and skin wounds. I don't want that. And if my heart stops beating, I don't want the last flicker of a memory of my life to be the crushing pain of young men and women cracking my ribs with their palms, or forcing air down my windpipe in attempts to give me CPR. That's not giving me my best chance. But how do you tell a family this? 3 grieving sons, all competent and caring 50-year-old men, who just want to spend time with their mother in her last few moments of life. I can explain these outcomes to them, I can try my best to describe them, but they haven't seen CPR on a frail old woman.
Yeah.
Let's go ahead and charge.
They haven't seen 80-year-olds with their heads thrust backwards and breathing tubes shoved down their throats.
You guys clear? Everyone's clear?
They haven't seen decubitus ulcers or bilious vomiting or loose stool half-heartedly wiped off the buttocks of their parents. Not yet, they haven't. How do I want to die? Not like this. So why is it that my opinion, that of a 31-year-old, is so different from these 3 other older guys? Well, there are a lot of reasons, and one that jumps immediately to mind, for me at least, is the oversimplification of options. Imagine you go to a supermarket, right, and you waltz down the cereal aisle. You're in a rush, you've got 1,000 things to pick up before dinner tonight. Eggs, milk, cheese, cereal, pasta sauce, paper towels, laundry detergent, and so on. And you're in the cereal aisle. But there are only 2 cereals, Honey Nut Cheerios or Corn Flakes. Alright, that's pretty easy. Cheerios is the obvious choice, so you move on to the next item. Now say you go to another grocery store. 50 cereals to choose from. Trying to decide is a little tougher. You think about how you've been craving something that's a little crunchy, a little sweet, but not too sugary, maybe something with a little bit of fiber, or it's low calorie. So maybe you get the low-fat granola, or the shredded wheat. You give yourself the best chance for a healthy, tasty breakfast cereal. In the hospital, when families or friends are confronted with an unprecedented situation, their father's had a heart attack, their sister stopped breathing, their wife was in a car accident. Here, doctors and nursing staff usually have the time or patience to offer only 2 options, 2 flavors of cereal. We can do everything, they say, or we can make your wife comfortable. Now, what kind of husband or daughter would you be if you told the treatment team not to do everything? It's horrible to even imagine. Sadly, we are limited so much by our language. I bet if you, as their doctor, asked them again, giving them more than 2 options, more than 2 cereals, they might feel more comfortable choosing a more customized patient care plan. Doc, I don't want my wife to be put on a breathing machine, but do everything else you can. Doc, I don't think chest compressions are what my father would want. If his heart stops, it stops. But if he needs help breathing, and you think the ventilator would help, then do it. And some hospitals offer these options. They have these variations of code statuses, rather than the just do everything or do nothing model. But in most situations, we're limited to the simplified, dichotomized approach. Do everything or do nothing. Now let's think about what happens when we opt to give a patient their best chance, and we do everything. Patients and families think that when healthcare providers offer CPR, it's a guaranteed life-saving measure. It's not. That's why you often hear providers describe the procedure like this. Mr. So-and-so, in the event that your mother's heart stops beating or she stops breathing, would you like for us to perform heroic measures in an attempt to restart her heart? Heroic measures. And when I say this to families, not that I'm an expert in it, I give them even more vivid detail, just so that they're not surprised when they see this and it actually happens. Mr. So-and-so, I ask, in the event that your mother's heart stops beating, or she stops breathing, would you like for us to perform heroic measures, including chest compressions, electric shocks, and inserting a breathing tube down her throat so that a machine can breathe for her? It sounds a little more violent, a little more invasive, I know, but the whole process is violent. It is invasive. And yet, it's the best chance we can give them. Now let's consider how effective it is. CPR, I mean. We put all this effort into prolonging the life of the patient, who has by definition just died. We perform CPR, we pharmacologically paralyze them, put them on a mechanical ventilator, throw in central lines, arterial lines, and often artificially cool their body temperature or sedate them to the point of unconsciousness. And you all know this. You've probably been in a code situation or even run one yourself. But have you actually looked at the data on how effective this is in the hospital? Outside the hospital, when a patient arrests, the likelihood of even surviving 30 days is somewhere between 5 to 15%, depending on whether you get early CPR. Pretty horrible odds. According to the American Heart Association, the odds of surviving that long may rise to 18% in adults and 36% in children. Still, it can be life-saving. 18% or 36% versus 0% without CPR. Best chance. Now let's say they get the CPR, and they happen to be the 1 in 5 patients who survive it. What are the odds that they're going to be back playing golf, or walking around the house? What are the chances that they'll spend most of their day out of bed, or even talking with other people? As it turns out, these odds are pretty good. In one study of nearly 900 patients who arrested during their hospitalization, 3/4 of them were independent in daily activities, and 83% were cognitively intact 1 year after their hospital discharge, as long as they survived the CPR. It's pretty shocking to hear these numbers actually, but the numbers are very different in elderly patients, or patients who undergo CPR and achieve return of spontaneous circulation, but they remain unresponsive. In elderly patients, maybe half are ultimately discharged to home, and in comatose patients who survive CPR, about half may even survive the hospital stay. So knowing these data, the outcomes with attempted CPR and aggressive care, giving patients their best chance, data I bet that a lot of physicians know, does that make us feel personally less enthusiastic about having chest compressions or being mechanically ventilated? Do doctors desire different care from what they provide to their patients? The simple answer is yeah, we do. Doctors want what they want for their patients, but the good ones won't impose their own wishes on their patients. They'll respect them, even if it hurts. Dr. Kendra Gorlitsky of the University of Southern California, who was interviewed by NPR on this subject a few years ago, said this: "I felt like I was beating up people at the end of their life. I would be doing CPR with tears coming down sometimes, and saying, 'I'm sorry, goodbye,' because I knew that it was very likely not going to be successful. It just seemed a terrible way to end someone's life." And I would agree. I think that a lot of us have been in this situation. And I definitely don't want to put my doctor in a position where they know that what they're doing is futile, or that it could leave me bedbound and breathing through a straw. And I'm not alone here. According to a 2013 survey of over 1,000 physicians, 88% reported that they would prefer not to have CPR if they're given a terminal diagnosis. And many that I've spoken to said they wouldn't want to be put into an ICU in their last months of life, that they'd rather die at home, surrounded by family and friends, or in hospice with comfort care. That's what they say at least. But is there evidence that doctors want to die differently? Yeah, there is. In one large cohort of deceased patients from Massachusetts and Utah, including over 20,000 physicians and 650,000 non-physicians, doctors were less likely to die in a hospital, less likely to have life-saving surgery, and less likely to be admitted to an ICU. Granted, these differences were on the order of 2 to 5%, but still they were significant enough to be published in JAMA. And overall, doctors seemed to be less aggressive with their own healthcare when compared to those who weren't doctors. These findings were corroborated by a second longitudinal study, also published in JAMA, that included over 400,000 decedents. The authors found that physicians were still less likely to die in the hospital, and less likely to die at any other healthcare facility. Kind of makes you wonder what it means when people use words like best chance. Best chance for a longer life? Best chance for a good quality of life? In a person's last months of living, these are often conflicting. And, so it seems, doctors preferentially pick quality over quantity. I will mention that before we wrap up the show, one paper I came across has refuted this notion that doctors die differently. In that 2016 study by Matlock and colleagues at the University of Colorado, the investigators retrospectively evaluated healthcare utilization among almost 10,000 U.S. physicians and almost 200,000 non-physician Medicare beneficiaries. The investigators looked specifically at healthcare utilization in the last 6 months of life among these patients. After adjusting for things like income and geographic location and other variables that have been associated with healthcare utilization, The investigators found no significant difference between MDs and non-MDs on hospital admissions, days spent in the hospital, or the likelihood of dying in the hospital in those last 6 months of life. That being said, there was actually a slight increase in the number of days spent in the ICU among physicians in their last months, a 23% increase in hospice utilization, and a longer length of time spent using hospice services. The authors concluded that based on this large cohort of over 200,000 people, physicians spend more time in the ICU and use more hospice services than non-physicians in the last 6 months of their lives. So, while physicians are more likely to use hospice services, which makes sense given everything we've talked about thus far, they may also be spending more healthcare dollars. But the jury is still out on these things. I'd love to hear your thoughts about our show this week. You can message us on Twitter at BrainwavesAudio or follow us at brainwaves.me. Next week, we'll continue the discussion with how doctors die differently when I interview Dr. Pamela Weibel, who practices family medicine in Eugene, Oregon, and founded the Ideal Medical Care movement. Stay tuned for that. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. Music this week was courtesy of Andy Cohen, Unheard Music Concepts, Rui and Lee Rosevere. For full disclosures and references, please check our show notes and the blog entries which accompany each of our episodes. That wraps up our show for this week. I'm Jim Siegler, and thanks for listening.